Good morning and welcome to our monthly webcast. I am Samir Mehta, your moderator. This is session number 179 brought to you with our partners at BroadMed AV. We have an interesting imaging guided left main bifurcation of a heavily calcified vessel, and I just think I overheard Dr. Kinney mentioning she's doing it via radial access. With this introduction, let me take you to the cardiac catheterization laboratory where Dr. Kinney and Dr. Sharma are standing by. Anu, good morning.
Good morning.
Did I hear you clearly? Is it wrist access?
Yes, show it. I think our wrist underrepresent our complex cases. But the latest data they showed for the NCDR as of the third quarter of 2023 in United States, the stable chronic coronary syndrome has 58%, and acute coronary syndrome has 66%. So average radial intervention in America now is 62.4. That's the latest data we have. So with that note, we welcome all of our viewers, which is 1 month less than 15 years. The life journey we started in 2009 together, and we'll show this very interesting case, complex. So we'll just try to get our presentation quickly and get to the point, which our supporters, then of course disclosures the same. Case number 179. 79-year-old morbidly obese patient presented with unstable angina, outside hospital, severe left main and 3-vessel disease, troponin negative, normal EF, and you see multiple risk factors on the left side. Look at the medical therapies in double line. I think very rarely I have the medicines written on 2 lines. There are actually 1 or 2 small ones which we didn't put it, but basically this patient has a severe 3-vessel left main, and because after the cath was recommended CABG, rightly so, but after discussion absolutely refused and sought Dr. Kinney for the intervention. High syntax score, 42, EF being 55%. So that's the plan. And now let's go to the angio quickly. What we see? Yeah.
So this is the left main, distal left main, 111 bifurcation into ostial LAD and LAD extending proximal, and then you have involvement of the ostial circ and the large you can say LPL.
Yep.
There's disease in the large LPL also, and I can just show you RCA is total, EF is good. Yeah, RCA is a distal total. You see there, bridge collaterals, some hypo of the base, but otherwise overall EF is good. EDP is good.
Anu, I think excellent demonstration case, genuinely complex lesion. Any concern regarding guiding catheter support for this kind of a lesion in a radial axis?
Yeah, I think what I would say, we have a VL guide that is so far sitting okay. This is where we are. We have a couple of pictures. I think the way we would want to do it is take a few pictures, but then try to do the PCI in one particular view. This is probably the best view where we can work on.
So Anu, you need to hear this. This is, I'm going to quote it exactly how Dr. Kinney will finish this case in 15 minutes, I'm sure. Sent to you by Dr. Nikhil Jha out of India. He posts very often, and I do trust his predictability.
But we go through the teaching point of view, and so right, I mean clearly that we don't want to present this that it's a case which we can take care. We of course we can take care, but this kind of patient has to have the regular heart team discussion with the. And to me, heart team basically is the family and the surgeon, because we recommend these kind of cases to go for CABG. But 50%, our paper just came out, and I'll show you next week that paper. The patients who we felt should go for surgery, but they came back, and we did the PCI compared to patients who are high risk for surgery. 2 and 3rd group was the routine patients who are appropriate for PCI. So OCC, Second is the inappropriate because referred for CABG but declined and came back to us. And third is CABG ineligible or from CABG high risk. So those three groups have a different outcome. So we were surprised, and this paper published in Journal of American Heart Association, our experience over the last 6-7 years, and we found 45% of these patients will come back to you. Let them have discussion, all the data, mortality, this, that, only one question they want to know. Am I going to die during the procedure? If you say you're not going to die, they say, okay, do the PCI, we'll look into rest of it later on. And this is the real life compared to what the guidelines are. So this kind of case, if we can complete our presentation, let's go back there. And then meanwhile, Anu, you're going to wire.
No, let's decide so I can do the work. Yeah. So I think what we will do is wire into the LAD.
Yep.
And reason I would want, ideally should be 175.
Yeah, 175. Yeah, it's 175.
But look
case.
at the LAD here.
Yeah.
See, one very important is this guy is morbidly obese. We will have, so you don't want to get into.
No, 175 is a good.
And how far you want to go? Only till the first septal.
Up to 1 p.m. I mean, that 1 o'clock there, a little further. Yeah, that area, yes.
See, if you go to 1 o'clock.
No, but just before that, before the septal, yes. With a 1.75 bar rota. And then we do a cutting balloon of the ostial circ. If you want to see, you can decide whether you need to do also rota of there or IVL of it. We'll have low threshold of IVL, but only problem we always say IVL, sometime hemodynamically, because you have to leave the balloon for 10 plus seconds. And so let's go back to our presentation quickly. We finish it.
Before that, some very relevant question. Upfront impella, and this is being asked by our friend Dr. L. Reyes.
Yeah, I would say that this case have been not the issue of the obesity, BMI 48. So I would say it's an appropriate case for impella despite near normal LV function because RCA is total. And that's one of the reasons. But in this particular case, we know one of the biggest disadvantage of this circulated, MCS, which we call, is basically their LV, the bleeding and vascular complication. So in this particular case, because of age, because of obesity, age is okay. I mean, about 80 is fine. But most important is because of the high BMI, which associated with high vascular complication. And we'll be ready with that thing. It really need to be done. Quickly, we can put a balloon pump / impella from the groin. We have put a pacemaker from the groin. And Will is our nurse and other
Jiong.
And Jiong. So all of them, they will be ready to control the blood pressure while things are going. You see the blood pressure is soft here. They will give Neo to bring the pressure to 120. But yes, ideal world, if there's no issue with the vascular, this is the case you want to. It will not be a part of the Protect 4 trial because they want EF less than 30%. But this is the kind of case in real life because of CT of the RCA is appropriate to use the impella. Yes, and that is indicated at present.
Another question, 7 French.
7 French, yeah. So this is the radial. As you can see here, we do maybe 10, not even 10%, I think 5% radial cases. The 5%, our simple, our webcast cases, we do maybe 1 in 2 years or so.
Anu just timed it 0.5 seconds to get the wire down.
Yeah.
Anu, you have your fan club fully in charge here, Dr. Jorge Enrique de Carvalho. She is brilliant.
And
I'm just quoting exactly as he wrote.
Yep.
Thank you, fan club.
So fielder wire, fielder wire followed by exchange with a rota floppy wire and a 1.75 bar. We are all ready to rock and roll. Let's go to the slide presentation so we complete that part. So plan there is imaging guided rotablation followed by mini crush of LAD diagonal, LAD circumflex left main and additional lesions of the LD and LPL. Now this patient, because of the left main and 2 to 3 vessel CAD, diabetic with high syntax score, will be maybe appropriate, but we say always after the heart team discussion, you can make it the A. After heart team discussion. So that's where we are now and we are ready to start. Always say that in these cases you have to have your balloons ready. So we have a 3.5 balloon ready on the table with the various...
And 2 wires, we have a run through and a fielder. The fielder that I used to get into the LAD, we will go into the, we'll use same. Yeah, we're going to circumflex.
Huh? Yeah, that's all right. That's all right. Yeah. And in this particular case, this patient on multiple anti-lipid therapy, you saw it. You name it, including on evolocumab. LDL is still 213. He's on.
No, it just started recently.
Yeah. So, but all the stat, the very high. A1C is better controlled now, is 7.2, and patient was on clopidogrel before.
No, we started him after we saw in the office.
So saw in the office because the TIA will not go with a more stronger antiplatelet therapy that is appropriate in this case. But in this particular case, because of the TIA, got clopidogrel, PRU is 194. But we saw that you can easily use the ticagrelor in these patients, while definitely prasugrel is kind of contraindicated because of TIA. Yeah.
Okay.
Good. Ready?
Yeah.
Okay.
Okay. Good.
Good.
So the plan will be we'll do rota of the left main to LAD. After that, we'll wire both the vessel. And since the lesion is significant, we will pre-dilate, okay, with the cutting balloon to the circ LAD, and then we'll do IVUS.
Anu, I didn't realize there is a new run-through wire.
Pull back. There's no new run-through, no.
No, there is a comment here that I've had a few cases of perforation with new run-through. I didn't realize there was.
Oh yeah, there was a one. Actually, we evaluated almost 3 years ago. We had a perforation also, so we don't use that. We go to the same run-through NS. So they came up with a little floppy, which was a hydrophilic tip. And we don't use that, but we tried actually, that was 3 years ago. Maybe it's available in India now, but 3 years ago was available here. We nixed it because the fifth case had a wire perf.
So I hope
same 3 steps. Yeah. Okay.
That is extremely useful information regarding this wire. So I mean, this is a 175?
Yes, 175.
Okay.
I'm coming back into the left main. Okay.
Good.
Okay, stop. So our goal was to go up to the septal. Get me the wires. Yeah.
Some backing of the guiding catheter, but very
I
beautifully
think that
managed.
is that's expected.
Fine.
So I'm doing one more run.
Yeah.
The polishing run, as you say.
Yes. Yes. Come
And
on,
you saw that hemodynamics, the systolic pressure always remain in 3 digits.
More questions?
Yes.
Role of IVL.
Yeah. So I think it's
I think like we mentioned, since the lesion is proximal, close to the left main, and we'll have to stay longer, there's a risk of ischemia here. We'll wire, and then we'll try to do cutting balloon first, okay, of the circumflex.
Anu, another very important question. Do you advance rotabur by dynaglide within the guiding catheter or not desired?
No, not desired.
Not desired, but in ostial lesions, ostial left main, ostial RCA, if need be, we do it.
But just coming out of the guide catheter.
Yeah, coming, because ostial RCA, especially if you have calcific ostial RCA and you got to do the rote of the ostial RCA, you will have an eccentric cut, but you will start in the guide. So I'll go with the run through to the LAD, and then we will get the fielder to the circ.
So
what size cutting balloon you want?
3.5. 3.5. Yeah.
So
I think larger, no?
Yeah,
very large left circumflex.
Yeah, I think bigger than that.
No, but let's use 3.5 for the LAD, and if you want to use 3.5 for foro, score flex, you want?
Yes.
And foro is score flex. Yeah, so just to say that, when the original rota was done in Europe, in the Arbeck trial, they were going forward with the dynaglide. The problem with that is, remember, at the corner of the guide catheter, the burr will come in contact and ablate the inside of the guide. So they rapidly realized and they stopped that technique. So basically we say that sometimes you can use it, but use it only when you're just coming out and you're there is little trouble getting out of the guide. So is not going into the vessel, little angulation of the guide coming out rather than pushing the guide, just with the Dynaglide advance into it. But there's no reason to put a Dynaglide in the, we can take the rotowire out now.
Okay,
there's no reason to use the Dynaglide inside the guide.
Such a useful teaching point, Dr. L. Reyes. I hope you got that and spread the message around. Excellent teaching tip.
Okay, what is this now? 3.5 cutting balloon and 4 score flex we can have there. Let's do the LAD first, 3.5. Let's complete one vessel.
So I will go to the LPL, and
yeah.
then we got to stent the LPL also.
Right, exactly. Good.
So this is into the LPL. I'll remove the rotor wire because now we have 3 wires. Rotor wire is coming out.
So question will come that after the cutting balloon of both Scoreflex versus the Wolverine, we do the imaging. What will made you to do IVL? I think that was the basically question was.
Yeah, we will once we look at the imaging, then we will tell you what is it that we will, based on what we will say, do we need IVL or no? Because I think management of calcium lesion right now is a very hot topic.
Yep.
When to do IVL is the question.
I think it is the other way around, when not to do IVL.
Okay.
Every
That's
IVL
true.
is becoming a, you know.
Yeah.
Okay, when not to do IVL.
No, clearly we showed the trend of the IVL use is already 6.9% in edge of the last year. We're going up.
Yes, going up.
Amazing, powerful transition of Johnson and Johnson.
Yeah.
Okay, down.
Two of the most
I'm going to
powerful
pull back here.
devices.
Go up here.
Yep.
So we're going 18 atmospheres?
Yep.
Yeah, 18. So this is a 3.5. I want to see there, make sure we are good. Yeah. You think we opened up? There's a little bit
So that's where we
not
think the
opened up.
IVL may be needed, but we'll see.
I don't want to go. Okay,
I was
go
on
here.
a recent
Going up.
physician expert panel where they voted that
Okay,
the
down.
most promising company in the future is Johnson and Johnson.
It looks that way now. They're coming
amazing,
in the
amazing.
back in
Take
the
a
player.
picture.
The back in the player.
Okay.
You need to go a little further in the LED. Complete that a little bit.
We
So
don't see it well. We have to change.
No, that's okay. We're seeing it here.
Okay, go up here.
You want to go a little further? Yeah, good. Low pressure, 12. So we are doing the proximal LAD. We have done the ostial LAD and left main and brought the cutting balloon few times back, went in, and we are doing again that proximal. Yeah.
Would you want to make a run into the ostium of the circumflex also?
Yeah, we have a 4 score flex
yeah,
for that.
because
so I think it will go.
It's a large circumflex, so
Very
that's
large,
why we didn't want to. Okay, good. Okay.
Yeah, this is 14 atmosphere. And just to say, Wolverine, you can easily go. It's a semi-compliant balloon with the 16 to 18 atmosphere. Yeah, go again. And the score flex is more non-compliant. You can go 24 atmosphere.
Another exceptional question, will you place stent till left ostium? And there are differences between European and American techniques, especially bifurcations.
Yep. Yeah, so, I mean, clearly this kind of case with the clearly 111, I definitely will go with the mini crush technique or DK crush, one of them, double stent technique. Although the database on the EBC1 is stepwise provisional, another approach with the European use. So I think it's a matter of fact.
No, European for this one will do culotte.
No, they can
are
do
a fan of culotte here.
No, Once you decide of the 2 stent approach, culotte will be the preferred approach for them. for the European.
No, his question was, will you come up to the ostium? But to me, ostium does not look involved, but
Of
will
ostium of
keep
what?
away.
Left main, you mean?
Left main.
Oh, no. Yeah, ostium
Not
of the
at
left
all in
main.
this case, yeah.
Yeah.
Ostial circ, yes, not the left main, yeah.
I mean,
I mean-
if it's not necessary, try not to come up to the ostium, because then engaging the guide, there's an unnecessary risk of LSD.
Right, and the ostium and the mid portion of the circumflex looked quite
Very big,
normal
yeah,
there.
yeah.
Samin, a question directed at you. Could you comment on the PREPARE study regarding Scoreflex balloon and long term?
Yeah. So no, basically, prepare calc trial was the scoring balloon, whether it's a Wolverine or angioscope.
IVUS is ready?
Yeah. And they basically showed that overall, compared to rotational atherectomy, that there was a little non-significant better in terms of the outcome, but at 3 years, they become positive with a lower TLR with a rotablation compared to scoring balloon. So purpose there was the original trial of the Rotexus, they used just a high pressure balloon, and then in the prepare calc, they used a scoring balloon of the both angiosculpt, Scoreflex and cutting balloon. Yeah. Where are you now?
It's in the proximal circ.
Okay.
If
Yeah.
I was trying to advance the balloon by itself, would not go. So then you wrap the balloons, bring it back into the guide, then advance the balloon. It has gone to the proximal circ. That's the technique to be used.
Yeah. So basically, the data from the prepare calc was that in about 16% of cases, in a calcific lesion, if you don't use a rotablation, you have to go up with some other technique. You have crossover.
What's the technique there?
Huh?
There. We have to pre-dilate the circ and put a stent.
Yep.
So you want IVUS first?
No, let's put a stent in the OM LPL first.
But you have a balloon, right? 3 or something you had.
Yeah. Yeah.
Yeah, give it to me. And then what we can do, yeah, I see that. Will is warning us some EKG changes.
Both vessels looking good.
Yeah, so far so good, yeah. So I think first we need to take care of the LPL. Proximal LAD will be taken care with a long stent from LAD to left main.
What's the stent type you want? What stent? But call for the stent now.
3015, 30.
Yeah, this one this is a good case for thick strut.
No.
Energy, huh? Then giants. Good.
Oh, you mean, you said thick strut. Thick strut is not Giants. I mean, synergy.
Means I'm saying thick strut of the synergy.
No Megatron.
Megatron, yeah.
Let's just do normal.
Okay, so this we are dilating now, the LPL with a 3O balloon, although we need a long balloon. Let's see.
No,
This
this
is
is
the
20.
20.
They are listening, our viewers are listening to your conversation, and
Yes.
now there is a question regarding the Megatron.
Yeah. So
No,
this is
a Megatron, same thick strut, but a large size.
it's a 91 micron. So I think with the big left main, I would say go with the Megatron. You know, so one of the original data IRIS study did show that synergy did not do that well in the left main, but I think the Megatron is a different story. Good.
Yeah.
So this could be the synergy in the LPL and then Megatron in the LAD left main circumflex left and so.
I would not assess. Come down.
Okay, 16, 18.
Think it opened up.
Yeah, but we have to have that
open up.
angle also. You need the long
Yeah, I know.
3.5, 38 synergy.
No.
You think that would go through the ostium of the circ as it is?
Oh yeah, it will go now.
Okay.
Have we taken care of the ostium of this LPL completely, or we need cutting balloon?
No,
there?
no, we are good.
Okay.
Go up here. This 3O is good. Yeah, but let's put science.
Anu, another excellent question. Do you stent from left main downward to adjust ostium or from distal to proximal?
Come back. No, which way?
Which way? Repeat the question again. Go up here.
Do you stent from the left main downward to adjust ostium or from distal to proximal?
No, it's a distal to proximal.
Distal to proximal, yeah.
Yeah, down.
And Samin, any difference in radial strength between synergy versus Zions?
Oh yeah, so I know Synergy has because of thinner strut, which is the various sizes that could be from 69 to 78 micron, 2.5, 3.5. You know, it's a
I'll put
differential.
Zions.
And
Can we change?
okay, just tell what you need. Yeah.
Okay, 30, 38
Yeah,
Zions.
so therefore, it's a thin strut. So definitely, I would say that the strength will be different with the Zions versus so. But once you get to Megatron, which is the 91 micron, things are a little different. That will be good strength. So left main, ostial lesions are the good case for the Synergy Megatron. Now, the Zions also gives you good, Zions is about 78 micron or 79 micron. So it still will be not as good, in my opinion, as of the Synergy Megatron. So
No, where
large
is the
ostial
stent?
vessel.
Open.
You want to take a picture or no?
Okay.
That's fine if you want to go there too. Okay.
Want
So
to
we
thank
Okay,
decided
can you-
Zions. Yes.
thank our viewers for so many questions. Again, several of them I answer, the more pertinent ones to our discussion and related to the case, I try to ask. So keep them coming. Thank you all for keeping it interactive.
And just to say that we are working and hopefully we'll give the news next month webcast that our online online relay will be CME sponsored. Whether it will get a 1.5 hour CME credit or so, we need to see. We are in the final phases of the there are two types of CME they wanted. One, for the active case, live case like this, when people will have some question in the end, and you answer those 1 or 2 questions, and you got your CME, credit. The other one is archive. So right now we are starting with the live cases only, having the CME credit, which will start in July. So we are just in the final phases. How will it work? What it will require? What are the requirements? So I think, to me, it should be that at least you have 2 questions in the end, 2 or 3, the question to be answered, and then it's but answer. I give the answer. I don't know then how will we change it? So there's a little tricky. So we are trying to learn those things now, that how it will be able to do a CME on the live, and they get a credit.
Well,
Okay.
one of the ways to that would be to give 2 or 3 minutes with your questions.
Good, no?
Yeah. Yes. Sine.
Okay. I have to go in a little bit.
1 minute. Yeah. Go 1 minute more. Yeah.
Okay.
IVUS for both the circumflex and the...
You will do that.
Yeah, we will do it. I'm taking care of the LPL first and then GOP. Yeah.
No, PVCs, I think the wire is in some small. Yeah.
TVP also.
Another,
Okay. Yeah, come on.
16. Yeah.
How high were you with the cutting balloon? That's another question. 8
Yeah.
to
So
10 atmospheres?
no.
So the Wolverine was 18,
Yeah.
and then we used the
score flex, which
to
was
the
went 22.
circumflex, 22.
So Wolverine, the rating burst pressure is 12, but you can easily go 16 to 18.
Okay, ready?
That's the key. So that's
So
not an
then
issue
I
at all.
can take the...
Hopefully useful for you, Alexandra.
Yeah. And Copstral did show they went actually 22 atmosphere.
Okay, so this one looks good.
Yeah.
So now we will go for the IVUS of the left main to LAD.
Yeah. Okay, let's get the IVUS ready.
I think other thing that we need to teach, which I try to tell the fellows also, like when we first did the pictures, right? We took couple of views, and later on you decide on one view, which is the best view we think we can work on the complex, and just stay to that view. And in the rare means a couple of times only you move the camera, so that way you're able to do the case faster.
Anu, for you, do you still sometimes use the Sabo technique?
No.
I've never used it. Dr. Sharma did it.
We did, but I can tell you a lot of restenosis we haven't used in last 4 or 5 years now. We did quite a bit at one point, but to me,
all I can tell you, my reaction here is how closely they follow you.
Yeah. No, the reason also, reason is physiologically, the way it was described never made any sense.
Okay, redo IVUS.
Okay, so I think we went all the way. Hold on.
So we have, I don't know, Samin, if you recall, I don't remember having, yeah, maybe we
Can you
once
see
had.
it?
Okay, I check the image.
We have
Yeah, it's
a
okay
viewer
landing zone.
from
Okay, I start
Ukraine,
pullback.
Yes.
We are showing IVUS.
It's coming. Pullback speed 4. Yeah, 360
Dr.
calcium there.
Alexandra
Kind of huge
Besenchik.
vessel.
Wonderful,
Yeah, a lot
Alexandra.
of
Nice meeting you.
Now coming to left main.
Alexandra.
Body is good. I will stop it. It's
Okay,
done.
good. To me, look like we have done a good atherectomy.
circ.
I am
Yeah.
not sure if we went all the way there, right?
Yeah, this is like a mid LAD.
Yeah,
Still
but-
there is a 360 calcium.
I don't think we
in
went
the-
there.
Okay. In that mid LED, is there a crack in the circle? That's the key.
No. We
Yeah, Dr. Sharma,
may
I
not
agree.
have
Some
gone
some
there
fracture,
even
some
with the
fracture
rota.
there.
No, we
Not
crack.
super huge.
That's
And
what I'm saying.
this
We
is the
have cracks.
IVUS.
Go to the circ now. Yeah.
Samin, you are thinking to answer the need for IVL, no? That's why if it is cracked, then you leave
Yeah.
it alone.
Yeah, exactly. So
Yeah,
that's
and-
basically, go do the circ now.
No, wait. Okay, let us go back. This is the, go to the distal edge, distal end of the LED, all the way back, down.
Sure.
Okay, yeah. So
Like
that's
here.
almost normal.
Yeah, good landing
Okay.
zone. Lumen is like a 3.3,
So we
maybe
went-
3.5 cent.
And then keep coming back.
Yeah. Now we found a 360 with some small fracture, but very focal here. And coming to the proximal, it's like a okay, like eccentric calcium
I
here.
don't know whether we went to the cutting balloon.
Yeah. This is a prox LAD.
Yeah.
Yeah, some fractures.
Use IV.
But I think we have done, we have done a good cutting.
I
think so.
I think atherectomy is over.
So question is, do we call IVL the atherectomy yet or no?
Let's
I
call
think you-
IVL.
IVL is IVL. I'm not sure because I think there is a crack, but still big circular lumen of that proximal to mid LED segment. I think to get a good the plaque modification using a 3.5 IVL, a few shots. I would not do it for left main. Now tell me left main, because biggest concern to me, I was moderating one session. I told them you're putting a left main RCA total just like our situation. They did not do atherectomy and they put IVL within 10 seconds with the second inflation, blood pressure became 40 because they cannot tolerate 10 seconds. So here, question is, do we in the LED portion where there was, should you use IVL? So I mean, it's just part of discussion. What do you think, AK?
No.
In the
It looks,
proximal to mid LED.
Yeah. I think Rota and cutting balloon has done his job. My only thing is that circle at the distal here,
here.
we may have to just go back with the balloon and dilate. We did not because it was 3.5, and I think we did not go here with the cutting balloon.
Yeah, then we use IVL. Get ready IVL 3.5. It's a 3.5 or
need it.
3 vessel. Yeah, good. Let's do the
Okay,
circ.
hold on.
Let's do the circ.
What do you think, Kiski?
Yeah, look, I agree. Just our issue is like a mid LED, like a 360 calcium, but it's kind of focal, like less than 5 millimeter. So I agree, like a tri balloon, and if it's dilated, we can go stent, I think.
Okay, we are doing the IVUS of the circ now.
Sure.
Get ready. It's a vessel is 3 or 3.5 there.
Distal edge is like a 3.3 lumen, so maybe 3.5 is like a okay.
Not 3.5 or 3.0? What do you have to do it?
Teach the right
No, take a
way.
picture. We have the picture, right? Let's see.
I'll go to the cranial view before you open. Wait,
Okay.
let me do the circ IVUS.
Okay.
Sure.
Now we are doing the circ IVUS.
Come closer. Okay, now we are in the circumflex. Okay,
Yep.
I'm not going to the first LPL
Yeah,
stent.
no.
Yep.
Just the proximal.
Okay. Could you flash
Huge
a bit?
vessel.
Sorry.
Flush.
Okay, I start pullback. It's a huge vessel. It's coming.
Wow.
Yeah, ecstatic.
Static.
4, 5,
Yeah.
huh?
Like probably 6.
The ostium and left main. That's it. I will stop.
Yeah.
Very fast IVUS.
Yeah.
I call it a OCT IVUS.
Pullback speed 4.
I think
Yeah, at least 5 lumen.
cutting balloon has done his job.
The score flex has done a tremendous job at the ostium.
Yeah,
How
I
is the
think so.
ostium lumen? That's the key.
There's a nodule, no?
That just the eccentric calcium looks
think
like not
so, or not
protruding, and the area is
I
great.
have to
So
finish those
I think it's
questions. You
go
do
to
2 minutes.
the stent.
Okay, now let me go to the cranial view.
I know another
You followed.
nice technical question for you. What would be your strategy in short left main bifurcation because the length to do pot is small?
Yeah, in that case, maybe decay crush.
Yeah, the other papers.
I mean, it is totally two separate origin, then try to do V-stenting, which we have shown also, I think. But it's really short, 1 to 2 millimeters. Okay, I am trying to do in the cranial, okay, angiographic view of the LAD, right? Ready? Okay, go. I don't think we went with the balloon here. See that?
You mean the mid portion, no?
No, just at the level of the septal, just proximal to the septal, we might have missed it. Means when it was caudal view.
So would that make you consider some more ablation in some
Uh,
or just a balloon?
my gut feeling, regular balloon will take care of it. Okay, but since you're saying when not to do IVL, right?
All I can tell you is there is a chorus of people wanting IVL here.
I guess go with the flow. Otherwise, I'll be one person on the other side of the river. Come. Oh, hold on. Huh? 3-5. Okay. So once we do the IVL, we are going to IVUS again.
Sure.
I think it'll be very hard to have an algorithm to convince people when not to do it.
Well, I just think that as much as there been a benefit, the ease of use has really made things totally different.
Delivery is not as
Challenging.
it's still challenging. They're saying a newer device is coming out. Okay, so let's go on the stenting technique here. Since the circ is a larger.
Yeah. I commented, I think somewhere in the middle of the
What's
case.
the largest diameter Zions we have?
Anu, another question, are you using any
Yeah, 4-5?
dedicated pot balloons?
No.
That was for you, Dr. L. Rice.
Yeah, so it's not available in USA yet. It's a dedicated pot balloon available in Europe and India, but not in America yet.
Because we do not carry. US doesn't have it. Never go negative when you prep. Never go negative. Okay.
Went through quite well. I thought there may be a little issue in the ostium.
Go up. Sure, there. 1 second. Okay, good.
So you're
Start.
up at 6
Yeah, 4.
atmospheres.
Right now 4. We are ablating. It already.
Opened out very nicely.
Yeah, 6. Good. Just one ablation. That itself is telling us that was. I think we need to have soft calcium and hard calcium. Okay, go up again.
In this case, looks almost like in the very early experience, many people were describing you virtually see the lesion melt in front of you.
What?
The melting butter sign is only one, yellow.
So another outstanding question.
Okay.
What is happening?
We see size differences IVUS versus OCT, how do you opt for size of stent as per
Okay.
OCT or IVUS? That is pretty obvious, I thought. Unless I'm...
So you already see the hemodynamics. Look at the blood pressure. Okay, yes. I'm going to do one more here. Okay, go up here.
I mean, I would have expected that in the left main, not in the proximal and mid LAD. That's a significant drop.
Exactly. And we didn't have that with rota, you see?
Yeah, no, this is very impressive. I've really...
Down.
I mean, I
Okay,
hope
go up here.
people understand what your concerns was
Yes, yeah,
about
yes.
the left main and...
IVL. And look now. I already have guide out, yeah.
You think that's because just
down.
of the total
Occlusion, yes,
occlusion
yes.
of the vessel?
Yeah. This is after doing. I want to do one more here because here, go up here. The reason is why I'm doing it. Once you are there, right, then let's do the inferior portion. See there? There's a lot of calcium. Go up. 4. You went? Go. Okay. 6. This time 6.
Did we get that guy from upstairs? Not there yet, right?
And after this, I'll come out.
Guy,
And then we'll IVUS quickly. IVUS is ready?
Yep.
Did you call the computer guy?
Let's just IVUS the circle. I mean the LAD. Yeah.
So, Anu,
Okay,
Dr.
down.
Jha has made a statement which I think is worth discussion, that there is this feeling that you oversize the stent when it is guided by OCT and undersize when guided by IVUS. Any truth to that?
Not really, but Kiski,
Yep.
can you comment on that? Because OCT, like we say, you are able to see the vessel better, right?
Yeah, OCT is like a higher resolution.
A higher
so-
resolution.
Yeah, so we can see more like a detailed intima, but stent sizing or something is always based on the EEL or lumen size. And for stent sizing, we use same, like based on the vessel OCT. And Renovate later complex trial also used like a same stent sizing criteria. So for stent sizing, like we don't like same criteria based on the IVUS or OCT.
Means use the lumen rather than the EL to EL. I never go with the EL to EL when it comes to sizing of the stent either.
Yeah, but post like MSA is based on the OCT is 4.5, IVUS is 5 or 5.5. That's based on the IVUS data or OCT data. That's the difference so far.
Okay, now. Opened up.
Yeah.
Opened up, and I think a little bit of a
Dissection.
I think a dissection also. Yes.
Yeah. Opened up probably too much.
Yes. 3.5 was a little maybe at the distal edge
aggressive.
was not. Yeah. Give me the OCT. Sorry, IVUS, and let's just finish the case now. So what we can do, I think, then we will do, since the circ to left main is a larger vessel, we'll go 4.5, right? Proximal was 4.5.
Yeah, the body like ectatic part is a 5 vessel, the circ.
Left main is how much?
Left main is also lumen is 4.9, like almost 5 left main.
Left main also.
Yeah.
But I don't want to put a 5 from left main to circ. Let's go 4.5. Okay, now let's start
Change
here.
the IVUS.
See
please.
what
IVUS. Okay, I check the
IVL
image.
did.
Okay, I start fullback. It's coming. It's a mid part. This is a good landing zone. And come to the 360. Yeah, 360 calcium is very modified.
Yeah, totally many dissection planes.
Yeah, I stop.
Okay, good.
Was there much of a dissection there, Kiski?
Second.
calcium plate disruption.
Yeah, just a
Yeah,
bit.
it's true. Much bigger lumen. It's well modified by the
So
IVL.
to show me the distal edge.
Distal edge, start of the pull-up. Yeah, we didn't check the prior IVUS. This is
Okay.
like a mid to distal part. Eccentric.
So there we are looking 3.0, right?
Yes.
Yeah, the lumen is almost 3.0.
Do you cover everything?
And proximal LAD is 4.0.
Best cell size is, yeah, at least 4 low. It's true.
So get us a 3.5. The question is then 38 or 48, right?
For the LED.
Hmm. 32. You want 48?
Yeah. This is the dissection.
What's the length you're getting?
So the initial idea was just 38, but if you want to cover everything,
Yeah, we have to cover everything now.
yeah, I mean the start of the pullback to the body of the left main is like a 53 millimeter.
No, but that we don't need. Not to left main. We are talking prox LAD because I'm going to stent from left main to circ. Okay?
Yeah.
That will be main vessel and LAD will be the side branch.
Oh, sure.
So the side branch will be from the ostium of the LAD.
Sure.
Yeah.
Then it's gonna be 48.
Yeah. The distal edge is not 3.5.
No, it's a tapering vessel.
Yeah. So I guess you have to put a 3.0 and post dilate it.
Yeah. I agree.
3.0 48 and then give us a 4.5, right? 4.5 23 from left main to proximal circ. With the IVUS, left main to circ.
Sure, sure.
3048. And then I want a 3.5 high pressure, 15 high pressure, ready? So that is left main to circ. Oh, you're getting 24? I said 23. No, I'm talking.
Yeah,
I'm talking
26,
kiski.
yeah, like a side by side size. Yeah.
$23 should be okay.
Yes.
Yeah, so we'll go to the, the only thing is I have run through in the LAD. Anyway, let's do it. Fine.
You can come back, Andrew.
No, because we always we like field in the side branch. So now we change the side branch criteria. That's okay. Ready. So side branch will be LAD. We are going 3.0 because the distal edge of the distal part of the LAD did not look 3.5. Okay, good. Connect here. Good. Give some dye and then we'll go caudal. Good. I have to go inside, right?
Be a little bit further.
Yeah.
Yeah, there
Some
you
dye.
go.
Some dye.
That should be just fine.
Okay.
Yeah.
Now I'll go get us a stent. Circumflex stent. Any other questions popping up?
You've answered something like 25 questions today. This is, and of course, I'll relate to you as they keep coming through. A wonderful audience. They have kept us intellectually on spot.
Go, I think, caudal. Oh, good. Okay, now go caudal.
Caudal you're using for
No,
positioning the
placement of the,
circumflex.
yes. So this is left main, you see that? Good.
That's the circumflex stent being.
My left main to left main, yeah. So now I'll pull back the LAD.
Okay, everything looks good. A little blockage.
And we call this Hitchcock's window. Go smaller so you can see it better. Because of the body habitus, you are not able to see. I'm pulling the main branch back. Okay. I'm going to go.
Okay.
You die.
Back in business. How does it look?
I think we'll look back. I think I'll pull back the LED back a little bit. Yeah, I think the circ looks good. I'm pulling back. We have side branch is LED.
Yeah.
LED little back maybe.
I mean, clearly with our Medina classification, the size of the vessel decides the main vessel.
Okay,
So circ is the main vessel, LED is the side because one is 4, one is 3.5.
Medina, yeah, okay, good.
Ready?
Yeah, go up with the.
Who has what?
Side branch, go up.
Good.
So we took a 48.
Yeah.
But this is a 3.0 because the distal of part of this LED was not 3.5.
Okay.
And then we'll post, okay? Down. Go up again.
And we have 4.5 proximal or 5?
This is a 4.5. I didn't want to take a 5.
Okay.
Though they're saying based on the IVUS, they're saying could go up to 5. Down. Okay, some die. Confirm. Then I take the wire out. Good. Wire of the LED coming out. Okay, go up with the circ.
Okay, we are going up now. (16 atmosphere).
Down. Actually, when we were doing the IVL of the LAD, he did have some hemodynamic changes with drop in pressure.
Wow. No, but I think the same. I said function of 10 seconds inflation, obstruction of the circulation is really key, and that gives the trouble.
Take this out.
Floor of this deflated fully? No, yeah, it's a big balloon. It's a 4.5 balloon?
4.5, yeah.
4.5 stent, okay. And we can have a 5.0 later for the pot.
Let's have a 5.08 pot.
Yeah, the 5.08. Let's do it. We don't have the pot balloon here, but they'll come. So pot balloon is 4-6 millimeter. It's totally horizontal, not tapering. And that's a really, so we always make the things which is the best suited for our technique. So pot balloon is a big, I would say, the news at present, out of the country, other places, and soon will be in America also. It's a simple thing. Okay, let's take a picture because then I have to start my presentation.
Good, good. You can start. I'll do the thing and we're good.
And in the end, you'll just show your both wires are out now.
Hold on 1 second.
Put one wire at least, the LED circ wire, let the circ wire go in. Good. Let's take a picture now.
Okay, ready?
Yep.
Beautiful.
Beautiful. Yep.
Okay, you guys finish your presentation. I'm going to pot first, recross, kiss, post dilate. Yeah.
Both vessels look great, but the circumflex is absolutely pristine. I think you may have to do something in the ostium and proximal part of the LAD, but
LAD left
very
main,
good. Yeah.
Absolutely. No, that's exactly the plan. So let's go through our presentation. One is the recent international publications. One is the Sydney 3 study of ticagrelor or clopidogrel versus DAPT post PCI. Then the nitrate CIN trial, the national trend in temporary mechanical circulatory support for cardiogenic shock on heart failure. This is not a MI, not a STEMI one, but heart failure. Then non-culprit, non-calcified plaque volume and plaque vulnerability and inflammation.
Yes,
and on the same topic, our focused review of the month will be pathophysiology of coronary calcification. Lot of data are coming, concept and the clinical implication of coronary artery calcification. So one is the Sydney 3 investigators. They have, from Europe, US, and Asia. They have various trials, published the meta-analysis of the global leaders, the Twilight, StopDAP2, Smart Choice, TACO, and StopDAP2 ACS. The single versus dual antiplatelet therapy. And question is single, should it be ticagrelor or should it be clopidogrel? So this basically was large number of patients, 25,960, of which 24,000 were included. 12th, half of them received DAPT, 8292 received ticagrelor, 3654 received clopidogrel monotherapy, and of course 45 received the prasugrel. So those were the patient population. What did we find? Very simple. Ticagrelor as the winner all throughout. Lower primary endpoint, lower bark bleeding, lower NACE, and lower mortality. All home run. So ticagrelor monotherapy after a brief episode of DAPT, whether it's a 1 month or 3 month, was associated with a better outcome. Now, was it for the clopidogrel also? Answer that is no. Yes, clopidogrel was lower bleeding, but NACE and all-cause death, no different. So therefore, from monotherapy point of view, we have the data solid for ticagrelor, not for clopidogrel, although cause less bleeding, but not in terms of other endpoints. And I think similar data like ticagrelor would be for prasugrel, but we need to get more cases. So this basically was the point. Second is nitrate CIN trial, which is the inorganic nitrate benefits contrast-induced nephropathy after coronary angiography from UK. So aim was because remember CIN occurs because of the nitrous oxide decrease and vasoconstriction. But if you give nitrous oxide, and actually it's supposed to be our NSL-16, was the nitrous oxide supplement, which initially was positive, then negative, but now we have the direct supplement of the inorganic nitrate by potassium nitrate. So idea was to replenish the endogenous nitrous oxide level, and hopefully that will give rise to lower contrast nephropathy. So this was the randomized trial against the potassium nitrate versus potassium chloride, and the data are clear. CIN 30% in the placebo, inorganic nitrate reduced it to 9.1, and then of course 1 year MACE. Look at that, 18.1 went down to 9. Then they have 1 year MAKE. The major adverse kidney events, they're defined as death, new onset renal replacement therapy, persistent more than 50% increase in baseline serum creatinine. That is called MAKE. So not MACE, MAKE. All were significantly lower in the inorganic nitrate group. And you see change in the serum creatinine at 3 months. Was the change in serum creatinine on the right side, inorganic, almost none, while there was a change in the placebo group. Same way, change in the EFR, significantly better, or very little change in EGFR on the right side compared to the placebo on the left side. So clearly, renal function, MACE and MAKE at 1 year, and this basically puts it together that by using the organic inorganic nitrate, there was decrease in contrast-induced nephropathy, improved kidney functions at 3 months, reduced cardiac events at 12 months, reduced kidney events at 12 months. Only thing was, there was also reduced mortality, but no difference in the new onset renal replacement therapy by using the inorganic nitrate. So this showed that it's a good agent, but it was given 1 day at the time of acute coronary syndrome before the angiogram and continued for 5 days. Then the temporary mechanical circulatory support utilization for patients with cardiogenic shock from decompensated heart failure, and this was more of a registry that what we have been doing for balloon pump, Impella, and ECMO. As you can see here, that overall mortality at 30 days has not changed. Whether you use a balloon pump, use Impella, because we have the bleeding, mortality, the stroke, and median cost. Biggest thing is the cost of ECMO. Look at the skyrocketing cost of the ECMO. So clearly that the entire study period, no change in 30-day mortality, bleeding, and hospitalization from any devices. Now then, the whole question was, which case we use ECMO, which case we use Impella. Both use have been going quite a bit, and they actually have a nice description of ischemic and non-ischemic cardiomyopathy cardiomyopathy. Ischemic cardiomyopathy, you use more Impella. Non-ischemic, you use more ECMO. Therefore, to sum up, they have ECMO use, balloon pump use, and Impella. That biggest increase has been on the Impella side. But question comes, ECMO we use when there is more comorbid conditions and more metabolic disease. Though basically they concluded the use of Impella and ECMO is increasing with an associated cost increase.
10, yeah.
The use of ECMO coincided with higher 30-day mortality compared with balloon pump in heart failure, cardiogenic shock. These findings likely reflect increasing disease severity and evolving practice pattern rather than causation. It's not that ECMO caused it, but where it was used, the sick patients. The last one is the higher non-calcified plaque volume is associated with increased plaque vulnerability and vascular inflammation from US and Japan by I.K. Zhang, who is the master. So what they did is they did both the CTA as well as the OCT in the patients, and they define high non-calcified plaque volume versus low calcified plaque volume prevalence and see what happens. You see the low, basically that you had high non-calcified plaque is associated with the higher lipid-rich plaque, higher TICFA, higher macrophage, higher microvessels, and of course layered thrombus, plaque rupture, but calcification not different because these were the low calcific plaque anyway. So basically that the high non-calcific plaque volume associated with various markers of inflammation as shown here. And also that there is a called pericoronary adipose tissue attenuation. That is a marker of inflammation. As you can see, it's the higher in patient with a non-calcific plaque compared to low calcific plaque as shown in this slide. So basically overall for various multivariate predictors showed that non-calcific plaque volume was associated with TICFA and pericoronary inflammation, and of course male sex and dyslipidemia associated with attenuation. So basically, who gets the worst plaque inflammation? High pericoronary attenuation and high non-calcific plaque volume is associated with very high incidence of TICFA as shown here. So clearly that is the combination of two which creates the trouble.
No.
And then you can see it on the IVUS that basically on the CTA angiogram that those are associated with higher non-calcific plaque volume is associated with increased plaque. And so therefore higher non-calcific plaque volume is associated with higher plaque vulnerability and vascular inflammation, the combination of pericoronary adipose attenuation and non-calcific plaque volume may help identify plaque vulnerability non-invasively. Remember we talked last month about the PREVENT trial, all focus going on at present about the plaque vulnerability, how can you detect by invasive or non-invasive. There is a very nice paper in this coronary calcium issue, in-depth analysis of that you can see current concept and clinical implication. These are the Italian investigator, and they went through step by step that we know coronary artery calcium, higher event rate. Everybody knows that. Advanced atherosclerosis because associated with more plaque and so. So question is, how can we detect early calcium? Is there some features of calcification, microcalcium at early stage, which we can detect and prevent hopefully the future event? So this they went through step by step, calcification of the various types, as you can see here in terms of the histopathology, the calcification, punctate calcification, combination on the angiography and histopathology and micro CT, then electron microscopy, that calcification, low magnification, medium and high magnification showing a lot of calcium and then the CT tells you about the spotty calcium, high density of calcium. PET CT with a sodium, fluoride sodium uptake can detect calcium at very early stage.
Distal.
And that's where the whole goal is. That this patient like CCTA we know always tells us the calcium, but by the time it's very advanced disease process. Whole question is, can we detect them early stages? And there is always a controversy that should you give statin, because statin will increase the calcium score rather than decreasing the calcium score, which have been shown. So IVUS use this representative case with a high calcium score, who has a high calcium on the IVUS, OCT, and you see the whole bead sign of the calcium in that LAD in that particular patient. This combination of various of the imaging will help to identify more calcium. And the goal is that there are new techniques also. One is a PET-CT, and then photon counting computerized tomography, PCCT, and double energy computerized tomography. These are all additional testing to decrease or to detect the micro calcification. An idea there is that time, so patients become more cautious about their health and hopefully will decrease associated subsequent event. There are laboratory findings also associated with the calcium various part, and conclusion basically was that although debate continues, decision withholding therapies in those with low or no detectable calcium. The question is, because the way we detect calcium, if there's no calcium, we say, well, you don't need statin, you don't need aspirin, but that's not true. If you get to the microcalcium, which we know that's the start of the atherosclerosis, that is a high-risk plaque feature, and that may be associated with the event, and that you can detect only on the PET-CT, PCCT, DECT, various newer techniques. So further studies with these novel technology will open the door to more accurate visualization of microcalcified areas within the coronary plaque, and better risk stratification, identifying those vulnerable patients who will benefit from more aggressive preventive therapy. And the various implications they have enumerated here. So let me just go to the take-home message. Ticagrelor is much better than clopidogrel mono versus DAPT in the post-PCI. Then inorganic nitrate, very, very better compared to placebo to decrease CIN and 1 year MACE and MAKE. Then ECMO, worse to Impella or balloon pump in cardiogenic shock patient caused by heart failure, and the non-calcified plaque and plaque vulnerability and inflammation, good marker. So coronary artery calcification has been associated with higher atherosclerotic burden and subsequent cardiac event. But the point is detecting at early stages with a microcalcification, so we can start the treatment strategy of various preventive therapy to improve patients' overall prognosis. Let me come back to the 3 questions. Following statement is false regarding the results of recent Sydney 3 collaborators regarding monotherapy versus DAPT post-PCI. Lower mortality with ticagrelor, lower bleeding with clopidogrel, lower mortality with clopidogrel, lower NACE with ticagrelor, and lower bleeding with ticagrelor. We know that mortality with the clopidogrel was not there, while it was there for the ticagrelor. Second, the following statements are correct regarding the results of nitrate CIN for reduction of events except significantly lower CIN with inorganic nitrate, significantly improved renal function, significantly reduced MACE with inorganic nitrate at 1 year, significantly reduced mortality with inorganic nitrate at 1 year, and significantly reduced new onset RRT with the inorganic nitrate at 1 year. We told you that there was no difference in the new onset renal replacement therapy. Third question, following statement is false regarding the association of non-calcified plaque volume in relation to plaque vulnerability. Higher plaque macrophage, higher lipid-rich plaque, higher pericoronary adipose tissue attenuation, higher calcification, and higher TICFA. Clearly, higher calcification is not associated with, because these are the non-calcific plaque to begin with. With that note,
outstanding review. So many different topics handled. My takeaway from what your presentation was that something really needs to be done regarding the cost of the Impella. I just calculated that the cost of just a procedure with Impella is 10 times the cost of open heart surgery. You know, so something like that is simply not going to run well in developing countries. But excellent presentation. A lot
and
of
that is true. I know, and that is true actually in India, in China, many places they use more ECMO in those high-risk patients than Impella, because the cost exactly is about 10 times. It's a 2 lakh rupees equivalent to 2.5 lakh rupees versus 14-15 lakh. So clearly it's a 10 times difference in the cost. So a lot of people use ECMO rather than using Impella because of the cost.
Second takeaway was the power of the Sydney 3 trial with 25,000 patients. That's a very impressive number. Excellent job, Samin. Anu, final angiograms of the case.
We'll show the IVUS final angiogram. And do you have this slide?
This now?
Stent sizing by IVUS OCT?
No, we don't have this one. No.
You have this slide available ready?
I don't
No, I
think
can
they
show
ever
it here.
showed it, yeah.
Because there was a question, how do we stent the sizing? Of course, I use my eyes. I know is IVUS, but I use my E-IVUS, E-Y-E IVUS. That's my eyes. So let's go back, show the pictures. Go back, go back, go back. So we did, go back. Yeah, this was the pot,
Yeah.
4, 5, same. We went into
Where
the
we
circ
left,
because the
yeah.
large, 8 millimeter. We went up to 18 atmosphere. And since it was a 4-5, we just dilated the circ. And then I just wanted you to see here, when you're in left main, okay, this is a 3-5 high pressure balloon. Okay, so I recrossed even before pot, but that's where I think there'll be a lot of controversy. People will say you got to pot first and then recross, because if you don't pot, your wire can go behind the stent strut, all these things. But you know, once you know you're in the lumen, you know how the wire gets into the lumen. I recrossed into the LED, but here look at how let it play. So this is a 3-5 15 high pressure balloon, and we were able to get it in. So that also tells us the wire is not behind the stent strut. Okay, so first you dilated the left ostial LAD, then we post the whole thing, then we did a final kiss. Okay, that's where we are. So when you do the final kiss, about 8 atmospheres or so, and then we did the IVUS. Let's show the IVUS.
Sure.
And then I'll go back to it. I don't have the slide ready, but I think we can show you how what is the guideline and how we do the assessment.
And you know, it's a rule of one. The OCT will give you 1 millimeter lower lumen compared to IVUS. That's the rule of one, always one lower. Okay, let's show the IVUS quickly, and then we show what you had to say.
Sure. So this is the pullback from the LED to the left main.
Yeah.
Actually, the distal edge is on the plaque, but no major dissection, and our stent is well expanded. The 360 part is area is 9.4, and our left main is like a 17, and the proximal edge of the left main is like a normal position, no dissection.
Yeah.
Then we
Now go back to the circ.
Sure.
So this is diffusely diseased vessel, and that is where there is no good landing zone for this, no matter what you try.
You say that pre.
We
So this is the initial pullback from the
This is
circ.
our final, look at the final cranial angiogram. Looks beautiful,
Yep.
angiographically, since we
Yep.
took 3O. Yeah,
Yep.
and this is the circumflex.
This is a pre. Yeah.
This is a pre, yeah.
Yeah, landing zone is a distal is a kind of eccentric, but lumen is like a 4.5 something, but it's an ectatic part. But proximal is kind of shrink like a follow vessel. That's why she decided 4.
So
5.
if you see here, the question was how we are going to decide on the stent sizing. So ectatic distal, okay, not normal looking, ectatic distal, see the diameter. So how do you get the diameter immediately below the yellow? 18.92, below that is 4.3, 5.4. So take average, becomes 4.5, okay? Now go to the proximal
Sure.
circumflex. So if you come to the proximal circumflex, okay, right there, it's telling you 3.1, 4.1. So you're probably averaging about 4.
Yep, for the
So,
lumen.
yeah, for the diameter to lumen. So that is where I think we could go. We said, let's go 4.5. Okay, now could we have gone 4.0 and post dilated? Now you have to take into equation the left main. So if you go to left main is almost 5.0. That's why we said, let's go 4.5 between left main to circ, and then we can post dilate the left main to high pressure. So our initial plan where we wanted left main to LAD changed once we saw the the circumflex size was larger compared to the LAD. So we made left main to circ, left main instead of, and then we made LAD the side branch. Going back to the point of, can we show this slide?
They can focus it here.
Focus here.
Can you focus this? Yeah.
See it very nicely.
Yeah, very nicely, yeah.
So this was the question asked, was the stenting size either by IVUS or OCT, and the guidelines, this is by the expert opinion which came way back in 2015 or so, always it says landing zone normal to normal, okay, but it's very rare in this kind of CAD where you have diffuse disease. You saw we try to be okay, but try not to land in the deceased. So when you say no disease means try no lipid, no calcium, and your plaque burden should be less than 50%. I think it was less than 50%. It's not that we saw that, but angiographically that's how it looked. Though they say EL to EL and round it up to nearest 3.25, means if you are 3.25, 3.45, you go to 3.0. And if it is a lumen diameter, that is what I use. Okay, lumen diameter, you round it up to the nearest number. And I think we made it clear. Okay, again, reference proximal to distal. So LAD distal was 3.0, proximal was almost 4.0, like close to 4.0. So we went 3.0, which is for the distal reference, and then we post-dilated the proximal. I hope it's clear.
Very clear, Anu. Also, a final, this has been a note of congratulations for you and the team. Somebody had called it a state-of-art demonstration. Samin, excellent case. You want to tell us something quickly about your meeting coming up, the conference?
Oh, yeah. Yes. So we have our annual Complex Coronary Symposium on June 14th. With the interventional fellows board review and nurse tech on 13th, and basically we'll do a 10 cases. This time focus is on bifurcation calcific lesions. All cases will be a bifurcation calcific. So all 10 cases will have some kind of atherectomy, rotational, orbital, or laser, and supplemented by IVL. I'm sure 50% will get additional IVL, and we actually have collected quite a number of cases, like 4 or 5 left mains, like this particular case, and of course a couple of cases will be with the use of Impella because of LV dysfunction, and rest just use the imaging. Try to use more imaging to get good optimal results. So also the data have come up now. The imaging in United States as of third quarter of 2023 has gone to 28%. Now Mount Sinai is about 28% this year. Last year we were 22 or 24. How much we were?
22.
22. So this year we are a little ahead of the ACC, our NCDR. We are 28% now in first 4 months of this year, and actually last year, last quarter of 2023, NCDR had a 28%.
Excellent, Samin. Great case, Anu. So many teaching tips, and I want to thank the audience for keeping it very interactive. We close today, and we will see you on June the 18th.